So today I'm going to talk about a randomised controlled trial on specific physiotherapy versus advice for people with subacute low back disorders. I did a bit of a mix up with the presentations. I did present it from an academic perspective after all on Tuesday, so we moved some things around and we're going to talk more about the clinical side of things today. Probably just useful for people sitting in the audience to have a think about where they sit on this continuum, from the novice to the clinical expert, because really what we're trying to look at in the STOPS trial is maximise potential impact by targeting physiotherapists in that sort of 85% group where we can change their behaviour and improve their patient outcomes. So what do these physiotherapists, these 85% of physios, do for low back pain? There's been some large surveys that show we look at impairment, we do manual therapy on the basis of those impairment findings. We think we can identify people with discogenic pain, and we provide mechanical loading strategies based on the McKenzie approach. And as we've heard, we do core motor control retraining. But there's a whole range of other influences that practitioners and their patients have when they're thinking about what sort of treatment and subgrouping strategies they need to look at. There's cognitive functional therapy, there's movement impairment syndromes, there's the treatment-based classification, there's very complex clinical reasoning strategies that Mark Jones talks about, again very complex psychosocial factors, and non-nociceptive influences. So really, again, when you're thinking about this population of physios, it's quite a daunting exercise for them to try and put all of this together into a framework and decide what's most appropriate. But more importantly, or equally importantly, does this treatment work? And we've heard some presentations about clinical practice guidelines. Whatever you think about them, they are based on the RCT literature and systematic reviews and the experience of experts, and they do guide decision makers and referrers to physical therapy, so they're important. And they show that some treatment is better than usual care or minimal intervention, but the effect sizes are small. And in these clinical practice guidelines, there's minimal support for the sorts of things that we're talking about with physios, McKenzie, manual therapy, or specific motor control. And there's no difference when one treatment is compared to another. It's been presented many times over the last 10 years that subgrouping may be the answer to this. Identify subgroups better in randomised controlled trials and provide more specific treatment. To explore this hypothesis, we've recently published 4 systematic reviews looking at subgroup-specific treatment, but unfortunately couldn't find consistent evidence that specific treatment actually is more effective. So why doesn't the research support the anecdotal clinical experience that we have that specific physiotherapy is effective? Have the clinical trials, even the classification trials, still got it wrong? Certainly even in some of these newer classification trials, heterogeneity continues to be a problem. There's one recent trial that recruited patients with a specific subgroup of low back pain, but included acute through to chronic patients, which clearly is a heterogeneous group and they're going to respond differently. Quality of treatment also continues to be an issue. The treatments investigated are quite complex often, they're often poorly described, and on the basis of that, not reproducible. So if you give a paper to a physio and say, go away and provide that treatment, it's quite difficult for them. Some of the classification-based trials have used a pragmatic design. So for example, they take McKenzie credentialed physiotherapists and they say, well, you go and do what you do with these participants in our trial. But it does, when you look at those trials in detail, there is still quite a lot of variability in what those practitioners provide. So these are some of the issues, perhaps in the classification and generic RCTs, that might be part of the problem. Have clinicians got it wrong? Maybe what we do is not as effective or as specific as what we think. Certainly, again, large surveys suggest there's a lack of consensus amongst clinicians with regards to diagnosing and classifying low back pain subgroups and a lot of variability. So there's potentially some work for us to do there as well. On the basis of this background, we formed a team, the STOPS team, Specific Treatment of Problems of the Spine, and aim to evaluate the effectiveness of specific physiotherapy compared to evidence-based advice in subacute low back pain. We've got ethics approval, we've recruited 300 participants, and we're still following them up to 2 years. Today I'm presenting the 10-week data. We had standard inclusion-exclusion criteria, and we defined subacute as 6 weeks to 6 months. So what are the points of difference with our trial compared to some of the literature First of all, we chose a population that we thought physiotherapy could really make a difference. So in the subacute population, you're excluding spontaneous recovery in the acute situation, and you're also excluding complex and potentially entrenched psychosocial and neurophysiological factors that you get in chronic low back pain. And we also excluded compensable, excuse me, with the complex social issues. We all are aware of the psychosocial model and the importance of assessing and treating psychosocial factors. But recently there's been a bit of a push to not forget the biomedical side of things. And in fact, in our trial, we used a biomedical pathoanatomical based classification system, taking into account the psychosocial dimensions as well. So this is the classification: disc herniation with radiculopathy, reducible discogenic pain, zygapophyseal joint pain, non-reducible discogenic pain, and one group which was where psychosocial factors and neurophysiological factors were the primary driver, which we called multifactorial persistent pain. So I'm just going to go through, again, this is sort of more the clinical side of it. I'm not going to go through all of the inclusion criteria as part of the subgroup, but just to give you a bit of a feel. Obviously, disc herniation with associated radiculopathy, they needed to have the clinical features of radiculopathy, and on imaging they needed to have a disc herniation which impinged upon the nerve root to give the diagnosis. Reducible discogenic pain, they needed to respond to Mackenzie's mechanical loading strategies. They needed to have the clinical features of discogenic pain, and that gave the diagnosis of an annular tear without neural impingement that was causing pain. Non-reducible discogenic pain is a somewhat more controversial subgroup. They don't respond to mechanical loading strategies. They still have the clinical features of discogenic pain. And it's the same pathology with a painful annular tear, but the hypothesis is that inflammation in that annular tear renders the disc non-responsive to mechanical loading strategies. Their joint pain, closing down pattern, regular compression pattern within the actual symptoms, comparable findings on palpation, and when you get them up in reassessment, you see a change in their movements and their pain response, giving you the diagnosis. Multifactorial persistent pain, this is a picture of a Rebro castle. If their Rebro was over 105 and they didn't fit into any of the pathoanatomical subgroups, we gave them the diagnosis of multifactorial persistent pain. So we recruited 300 participants, we classified them, we then randomised them into either subgroup-specific treatment or evidence-based advice. A little bit more on the treatment again, sort of just to give you a bit of a broad overview. For reducible discogenic pain, mechanical loading strategies, taping, postural advice. For the other discogenic problems, we treated the disc herniation radiculopathy the same as the non-reducible discogenic pain. A functional rehab program, taping, postural advice, and medical management as well as self-management of the inflammation, which is again hypothesised to be a part of non-reducible and certainly is a part of disc herniation with radiculopathy. I have to try and fix that, but importantly, the rehab program was pain contingent, so the progression of the exercises was contingent upon pain, and I'll come back to that in a second. Z-joint unilateral mobilisation and manipulation procedures, progressing into combined movements and using, we think, reasonably sophisticated clinical reasoning, decision-making algorithms based on the Maitland approach. Multifactorial persistent pain, a rehab program again, advice and a cognitive behavioural approach. And rather than the rehab program being pain contingent, the progression in their exercise was time contingent, consistent with a cognitive behavioural method. All groups, except for multifactorial persistent pain, received the motor control program. So the motor control program wasn't actually specific to one subgroup, apart from not being in the multifactorial persistent pain group. So transversus abdominis, multifidus pelvic floor, progressing into functional positions. And what we mean by a motor control program is obviously identifying abnormal motor control, trying to normalise it, using specific retraining, and also addressing the kinematics that you've all heard about in the previous presentations. I've just put this up because there seems to be some controversy about this approach. Obviously, there is some inconsistency with some other researchers around motor control, but the evidence is fairly overwhelming, and this is an important thing to do as a physiotherapist. In terms of addressing some of the treatment quality issues that I've identified with previous studies, we've described the treatment protocols in 4 separate papers. We have attempted to make the treatment reproducible. There's about 40 patient information sheets that the patients got depending on which subgroup they were in. An extensive manual, extensive decision-making algorithms to assist the practitioners in negotiating the way through the treatment. Rather than a pragmatic approach, we recruited practitioners of varying experience, trained them up, had monthly telephone hookups, and reviewed their clinical notes at week 3 and 7. And we tried to find a balance between complex and non-reproducible treatments and overly simplistic treatments. 10 physios in Melbourne provided the treatment, 10 sessions of specific physio, and 2 sessions of advice according to the principles of INDA. Just some examples of some of the patient information sheets. Shows you sort of nice pictures of the exercises, nice descriptions of the dosage which the practitioners used as required. This is one of the decision-making algorithms based for the reducible ischogenic pain group, and you can see a reasonably sort of complicated algorithm which really helped the physios negotiate their way. We use standard primary and secondary outcome measures. We analysed between group effects. And the results, we screened 2,000 volunteers to get our 300 participants. We had very low dropout and very low loss of follow-up. And I'll spend some time on this slide because this is really the main results. So if you look at, on the left-hand side, if you're getting standardised mean differences, on the left-hand side that's favouring advice and obviously favouring specific treatment on the right. Needing to understand effect sizes, so this is not an absolute scale but a statistical scale. 0.5 is considered moderate and also clinically meaningful. So again, contrasting this with some of the research in the clinical guidelines, the effect sizes are small and not clinically meaningful. Confidence intervals, if they're crossing the y-axis, they're considered statistically non-significant, and if they're not crossing the y-axis, they're statistically significant. So you can see your outcome measures here. At baseline, both groups were the same, as you would expect. And at 10 weeks, for back pain and leg pain, moderate effect sizes that are clinically meaningful, favouring the specific treatment. And small effect sizes for oswestry, also statistically significant. Just to give you some sort of a bit of a better outline as to what this means in absolute terms, these graphs represent participants who have improved by at least 50% from baseline. So you can see at 10 weeks, specific physio for back pain, 63% had improved by 50% compared to much less for advice. This is statistically significant. Similarly for leg pain, similarly for global rating of change. And when you look at patient satisfaction, much higher participant satisfaction in specific physiotherapy compared to advice. So we believe this is the first high-quality classification-based randomised control trial to show moderate and clinically meaningful effects on subacute non-compensable low back pain. We think the reasons for success are getting the research methods right and also getting the clinical side right. And we believe that if the treatment integrity measures that we've outlined are followed, the STOPS protocols are reproducible for practitioners independent of their level of experience. And so again, thinking about yourself as a practitioner and the practitioners that you mentor, if you are in this zone, we think STOPS is a potentially good thing for you and your patients. There's some limitations in the classification system. We need to do more work, but the fact that the trial showed results is evidence of the validity of the classification. We need to explore in post-hoc analysis psychosocial and neurophysiological factors a little bit more. And we need to do this trial against placebo and also against other treatment types. So that's the conclusion. Thanks to Lifecare who funded the trial, which was fantastic. Thanks to the STOPS physios. And if you are interested in finding more about the treatment protocols, we're on social media. And thanks for coming to our unplanned session.